Hey, this is Ash from All Things Dentistry, the place where we're passionate about sharing those unwritten hints and tips of dentistry. Well, welcome back. This is part 2 of a 2-part series tackling this maxillary first molar. In the first part, we talked about the pulpectomy and literally kind of the 20 tips, if you can imagine 20 tips on how to tackle a severely curved and a calcified maxillary first molar and a pulpectomy. Here, what we're going to do is we're going to finish our cleaning and shaping and look for MB2 and obturate this case. So what we're going to do is I'm actually going to fast forward through getting into the other canals and removing the calcium hydroxide, because I'll put that in another video or at the end. It's not that important for this. I really want to focus on dealing with MB2 and a bunch of tips coming out and dealing with MB2. It's pretty exciting. So what we're going to do here is we're just using a long shank, back to the long shank number 4 round surgical burr. That pink stuff, if you're wondering, is a resin modified glass ionomer called Triage. And look at that, voila, we are into the pulp chamber. So just to situate the ground, this is the MB1 canal. This is our distal buccal. And let's focus on it and look at this. This right here, my friends, is quite the most remarkable giveaway possible. Now we're looking at 6 times magnification through the microscope. And these little white lines here are possible indicators. And you have to think we've taken the calcium hydroxide out of all the canals. It's rinsed and cleaned. Now we're looking at MB2. Everything has been cleaned and shaped to a 3506. They are sitting in sodium epichlorite right now, removing any of that remaining vital tissue. And we are looking at the dead giveaway of MB2 is the white line. What we're going to do is we're going to trough these white lines. Now, the key for troughing is to trough to the mesial and towards the palate a bit. So what I'm using here is a long shank Muntz burr. It's being spun around 10,000 RPMs. And the beauty of the Muntz burr is 2 things. Or any long endotracer burr is the same thing. And the beauty of it is that the head of the handpiece is way out of the way. And the thing about round burrs versus ultrasonics, if you really want to get into ultrasonics, that's amazing. I'm happy for you. The problem is that if you use a pointed tip on your ultrasonics, they will create this white line. Round burrs do not. They fill the white line. This little white line is a beautiful trough. It's an indicator of MB2. So let's go ahead and trough that out, that MB2, with our round burr, our long shank Muntz burr. One of the things that's going through my head is I'm praying to the endo gods, please do not disappear, because I'm not for certain there's an MB2 in here. We all know there are MB2s in almost every tooth, but I'm hoping it won't disappear. But it seems to disappear. Maybe there's a little bit here, but I can tell you folks, the secret is right here. And that's what I love about showing this case, because it's one of those rarities where it actually talks about, and I'll show you the picture right beside me. It's another video that talked about how MB2 travels horizontally, and it is traveling horizontally right here. But I don't know that at the time, so I'm just going to keep tackling. What I'm doing is I'm really putting a lot of, not pressure, but I'm using a brushing technique along the mesial side of that burr. So the mesial side and kind of the apical, look at that. It's kind of the apical side, and I see this little magical dot. Boom. Right there, folks. That is the magical dot right there. That is MB2 with almost certainty. So when I see that and oh, it disappeared. Dang it. So that was like a magical moment, and all of a sudden it disappeared, and that happens. But I can tell you there is an MB2 in this case, and that might be it right there. So that's what's going through my mind. And what's really funny is that as I'm doing the procedure, what goes through my mind is I'm trying to keep it in focus, but I'm also trying to get MB2, and I'm trying to do this as efficiently as possible. So we're continuing to, remember, like I just talked, MB2 travels horizontally. So instead of driving apically and perforating, which is completely possible, what I'm doing is I'm moving more mesially now. And what I've actually done is I've moved up to a larger round burr, and just to get a little more surface area on that, so I'm not digging right in. And what I wanted to do at this case was I wanted to actually make a path to the coronal surface with my Muntz burr to kind of make a channel so I can get everything in there a little bit easier, be able to see. And look at that. There, it back again. And you can see how, look at all the debris. And one of the things that really is critical is to do this dry. So all this stuff lights up. So this is debris or even pulp tissue, but mostly it's debris getting put into that MB2. And you can see it's on the side of the wall. So I'm slowly troughing away. Now, what you can do, and it's totally within the rules, is to just literally continue your access out like this with a diamond burr, a long shank diamond. I've done that for years. Here I'm trying to be a little more conservative, but you know what? Honestly, this is restoration. Make your life a little bit easier rather than trying to tackle this with a Muntz burr at a weird angle, because back up here, I'm trying to push into the rubber dam a bit to try to get access into the situation, into the MB2. So we're going to rinse out, remove all that debris, and let's take a look at what we have. There it is. It's magical. That's MB2 still. And it's super, it's great to see this because even after I've removed all the debris, it's still there. There's that little white line. It's very faint. And what you can tell is, see where it's traveled from? It was like about here. And now we've moved it mesially a bit. And that's one of the critical things, and not trying to burn through the furcation, because that's really easy to do. So it's a mesial movement with your Muntz burr. What I'm trying to do here is I'm actually trying to dry it a bit. So look at this, just so it kind of pops out. It pops so everyone can see what's going on. And that's that debris right there. So what I elected to do, and since you've made it this far in the video, I'm just going to tell you straight up. What I find, and I have the confidence with reciprocation to take that reciprocation. It's a brand new file. This is, I think, so this is a 25 millimeter file. It's easier with 21 millimeters. I'm telling it's 25 because I can see the band right here. I'm going to use my reciprocating file to see if I can get access into here. And when I see that, yes, it's dry. That's a no-no. But what I'm doing here is I'm just kind of doing a scouting. So I'm trying to see what's going on. And I think I changed, yes. So now you can see there's only 3 bands. So 18, 19, 20. This is a 21 millimeter file. You can see it's easier to get in there. I put a little bit of a bend on there, and I'm literally just placing that file into that little white dot and see if I can get some movement. There's lots of different ways to tackle this. And one of the classic ways I've done it is to actually use a Muntz burr to make that channel a little bit bigger and use my shorthand files and try to get shorthand files down there. As I progress with age and experience, what I've done now is I have more confidence with just reciprocation and using my Wave and Gold. Oh, I didn't even say this is a small. So I'm using the Wave and Gold small just to see if I can get any traction and any movement. And what I'm doing here is I'm actually using EDTA as my lubricant in this situation. So we're starting to get traction. And let me go back here as I'm talking. I see a little bit of debris in my flutes. I'm like, okay, sweet. We're starting to get some movement. Now, I don't do this with rotating files, so I couldn't tell you how that works. I'm too scared of breaking them, but my reciprocation files, I have no problem doing this. But I do change them out frequently, and while I'm doing this, I'm just doing pecking. So I'm watching 2 things. I'm watching the distance between the tooth and seeing if it's going apically, and I'm also watching in the mirror. Now, what you're also watching, just like if you've missed in the first video, it's exactly the same thing. I'm doing a little peck, bringing the file back out into the ear again, and because it's got this weird shaking motion, it actually knocks the debris off of the flutes, and then I go back in. If you don't do that, there's a high probability of fracturing your file. Yes, this is really against kind of all the rules. There's no glide path at all. That's why I love reciprocation. It kind of follows the channel, follows whatever's there, and makes it happen. So what I've done there is I've actually changed out my file. It's a brand new, fresh file. And I'm literally just using the feel of into that MB2 to access into MB2. So what you can see here is we're slowly making more motion. We're making a lot more traction. We're getting further down that canal just literally by using my Wave and Gold Yellow. I'm not sponsored by Dentistry, and I just use their products. I love Wave and Gold, and I love it because I'm confident that I can do this, but it's within those parameters of making sure my flutes are clean every time that comes out. So every time you see the handpiece go down, it's actually going into MB1. So I move it back, reset, and back into MB2. So the next challenge is really, so once we, I mean, the question you really might be asking is like, how long are you going to do this for? I'm asking myself that. How long am I going to go for? So I actually can't remember what happens. So let us watch along together. I'm leaving this video with it not running in high speed because I really want you to be able to see how frequently I'm actually cleaning those flutes. I'm not changing on my irrigant a lot. It is EDTA, but I'm looking at my tip of my apical tip of the file, making sure it's not broken. I'm checking where it's cutting. That's what I'm doing right here. It's cutting kind of right along there. Tip still attached. I'm running it back in the irrigant, making sure that the debris is getting knocked off my flutes and then back down. The beauty of reciprocation is that it's a self-centering kind of technology, just the way it is. And I have a lot of confidence it's not a fracture. The problem is that it's really slow. It's super inefficient. So I can't remember if I'm going to switch out from EDTA. Maybe not. Might still be EDTA to sort of still EDTA. We're going to rinse out all that debris. And at some point, I need to check. I don't have a CBCT, so I need to check to see if these canals join. Okay, so one of the tips I talked about in the previous video is using cotton forceps to place your file into your canals. It is so much easier. Almost repeatedly do I place, instead of using my fingers, I'll just use cotton forceps and boom. So what I'm going to do now is we're going to check to see how it feels. Am I, one of the things right off the bat to see, to feel, to sense. Unfortunately, that's the way a lot of endo is, to sense, are these two canals joined, is if the file just drops. And if it really just drops, what that tells me is there's a high probability that it MB2 joins MB1 because MB1 is already clean and shaped to a 3506. All right, so we're going to keep going down the road here of our Wave and Gold yellow. So this is a 2007 file. This is a 25 millimeter file, and you can see the difficulty I'm having as compared to the 21 millimeter file to get that into the canal. What I'm doing there is I'm bending. So watch, I'm bending with my fingers. All right, I'm putting a good bend. I'm pushing back on the rubber dam and frustration. And I'm leaving this in here so you can see the frustration. Now, the way to prevent this frustration is to remove a little bit more out of the mesial wall or angle the handpiece back into the rubber dam a little more distally and then come back at that angle. If you're newer or you're intermediate or more of a beginner, honestly, opening up your access, removing that amalgam a little bit more makes life so much easier to do the access. Don't try to do these. This is not even a ninja access. This is a standard access. And it's difficult to get that file in there. What I forgot to mention is that what's really interesting is that this patient was having this root canal completed because they had cold sensitivity and they were done with the cold sensitivity. They had periodontitis, they had apically positioned flaps, lots of cold sensitivity, so we're actually going to do the other side as well. I've elected to get a cone beam of the other tooth, but I already know what the anatomy looks like in this tooth. So we'll confirm the anatomy in the other tooth and then confirm the obturation in this case. But between the pulpectomy and this cleaning and shaping the MB2, the patient said that there was a little bit of sensitivity in the tooth. And that reconfirms my experience in doing endo when, especially even with a middle mesial canal, if I've missed that and during a pulpectomy and the patient comes back and we finish the case, and I find that middle mesial or the MB2 in this case, and usually their cold sensitivity goes away. Not all the time. I have another case where you'll see that sometime. I still haven't treated it, but still cold sensitivity after endo. Now put in the comments below if you still have that. If you've had a case like that where there's cold sensitivity after the endo's done, and MB1, MB2 is completed. Maybe there's a distal buccal or distal buccal 2. Sorry, maybe there's a DB2 that I missed. So we're getting a cone beam on that, and we'll evaluate that at a later time. This is a really great tip that was taught to me by my buddy Les. If MB1 and MB2 join, usually the working lengths are going to be about the same. If MB2 does not join, it's going to be roughly a millimeter short. And here is why. See this picture beside, on the screen here? MB2 is usually at the bottom on the way down the mountain. And that's a great tip because it's super helpful. It's just think if MB2 does not join MB1, it's usually a millimeter short. That will save you in many times. And I wish I knew it 10 years ago because it would have saved my butt then. If I have time, I'll talk about that. So here we go. So now you can see we have MB2, MB1, and look at the difference. Look at how far mesial that has tracked compared to where that initial little I'll put the picture up on the screen here where the initial little white line was. So that's pretty standard for what MB2 is where it's going to be. So the next challenge is to see if they join. So this is a great tip. And the simplest way to see if they join, what I'm doing here is I'm just doing some what's called manual dynamic activation. It's a really simple technique of activating your irrigant with your gutta percha point. It's really cheap compared to buying a laser. Fairly effective. Got to be careful you don't extrude a lot of sodium chloride or irrigant out in the apical tissues. So what I'm doing here is I'm checking to see if these two canals join, and guess what? They do. So this is the 15 file coursing through the gutta percha, and now I know that X number of millimeters from the tip to where this pierce is where they join. What's really interesting, this is the endoactivator, is that even though they joined, he still had cold sensitivity. Now, I don't know how you can explain that because at the end of the pulpectomy, if you watch the video from before, I actually open the buccal canals to a 3506 and the palatal canal to a 4505. And how that MB2, because it still joins, how it had sensation and giving him cold sensitivity, I have no idea. And I confirmed it with him the day after to say, hey, listen, how's your cold sensitivity? He said, it is completely gone. It blows my mind, this stuff, completely. So we're going to activate our irrigant, and what that is doing, there's so many different ways of doing this. I'll use the endoactivator here and there, and really what we're trying to do is we're trying to not, it seems like it's doing nothing, and sometimes I think it's not doing anything, but what I have to think about in the back of my mind is that it's taking the debris from the apical parts of the canal, putting it into solution so I can rinse it out. That's really critical, to get all that debris out of there, rinse it, and get it into solution so I can rinse it out, so I don't block myself. That's one of the biggest issues, is blockage. But also, imagine necrotic debris. You don't want that stuff floating around. So we're going to be doing our final rinse, final irrigation with sodium epichlorite. We're rinsing out any of that. So that was our sodium epichlorite rinse, and now we're activated it. Now we're going to rinse out. So I'm blowing air onto my paper points, and what that does is it dries out the pulp chamber, and it kind of wicks up the moisture from the apical parts of the canals. I'm on the fence about that. But what it does is it definitely dries the pulp chamber without causing kind of an air emphysema. That's really critical. So I'm not blowing air right down the canals. Our paper points are in the way, so it blocks that. And then the other thing you can do with your paper points is you can use it to confirm your working length. And that's what I'm doing here is I'm just measuring where it's wet. I can't remember the lengths. And then we'll see me do that with my MB1. I'm going to place that to length. I'm going to take my cotton forceps at my reference point. I'm going to pull that out. We're going to tap the bottom of the paper point. It's wet. I'm going to measure it, and so on and so forth. You need to dry a few times just to make sure that they're fully dry. Especially when MB2 joins MB1, there's usually a lot of irrigant down there at where they join. So it takes 3 to 4 paper points when two canals join. Okay, so we're going to go ahead and do our obturation. I have skipped, I'm sorry, when I cut this video, I have skipped cone fit, so that makes way more sense. We've already fit our cones, and now we're going to take our cone fit radiograph. So we're placing our BC sealer, we're just placing it in the coronal 2/3. You can see it popped up through MB2, indicated that they joined, but it doesn't always mean that they join. It does mean they're joined, but it doesn't mean that the apices are the same. Just be careful with that. And then what we're going to do is we're going to take a 10 file and just kind of pump our BC sealer up and down the canal. I'm not injecting all the way down to the apical third, and this will be very careful. And we're just taking the file, we're going to run it to length. And one of the things you need to be cautious of is if this was a necrotic case, don't be I think it's highly recommended you don't take your necrotic files with all the necrotic debris, and place them back to length with your sealer in there, because you're just placing more bacteria. And I actually learned that when I was listening to Shannon Patel. So I'm really grateful for that lecture I was listening to. He's an endodontist in the UK, amazingly skilled gentleman. You can check out his Instagram here. What a great tip. And I only learned that a few years ago. So, I mean, you're always learning. So we're just placing our cone of, remember I cut it, I cleaned and shaped MB2 to a yellow, and I've clipped the end of that about 5 millimeters because that's where the canal joins. We're just placing our canals or gutta percha points. And like I said, I've already tried these in with irrigant. So now we're just, rather than wasting time, we're just going to, in the video, we're just going to skip right to the obturation stage. One of the most important radiographs you can take is the cone fit radiograph. So I'm doing a cone fit radiograph with sealer. That is, to me, so important because I can change, I can move gutta percha points around, I can reshape canals, I can do a whole bunch of things. This is the most critical radiograph we're going to take here. And you can see, even with a traditional access, it's pretty tight in there with our cones. Pretty tight. So I'm just placing that sealer to length. Oh, I remember what happened here. So sometimes, put in the comments below, and it was crazy, but he actually felt a little bit of, and I do, I make sure there's solidly numb, and there's a PSA block on here. He felt a little bit when I placed that gutta percha point in the palatal canal with the sealer, just a little bit of extrusion. So put in the comments below if you know what I'm talking about when your patient feels a little bit. And it was only, we're 30 minutes into the procedure, so I'm not sure what happened. We have pulpal anesthesia with articaine for up to 45 minutes to an hour. So it's very interesting. I felt bad because that is the last thing. I know what dental pain feels like personally, so it's awful when you're not expecting it. So fortunately that goes away, and now we're just going to sear our cones. I'm going to let this play out so you can see kind of sometimes these go smooth, sometimes they don't. We're just slowly removing any of the gutta percha. Nice and easy, making sure, nice and easy, lemon squeezy. We're not trying to pull. What I'm trying to do is I'm literally like an underwater investigator, if you imagine. Like I'm a treasure hunter. That's what I'm looking for. I'm hunting for treasure. I'm hunting for the orifices so I can sear the gutta percha right off at the orifice without trying to pull it coronally. Because I know that you know what it's like to have gutta percha points come all the way out when you're searing them, and it is frustrating. The preparation I'm using here is called the apical stop preparation, and I'm using single cone technique with BC sealer. So even if a cone does come out, I can replace it with a fresh cone, and 9 times out of 10 it goes right to length because I'm creating an apical stop, and I don't have to worry about tug back, none of that nonsense that I learned in dental school and in residency that I just was so frustrated with. And what I'm doing is as I'm kind of peeling away, I'm making sure that before I pull my heating instrument coronally, that I'm touching tooth structure. So what that does is it causes it to cut versus just kind of heat it up and pull. I'll get it to like the 80%, and then I'm going to take my Buchanan plugger. I'm still using these. It's crazy. You don't need a Buchanan plugger, but these are from the old technique of continuous condensation. And I'm just going to kind of burnish the orifice of all the canals. And then what we'll do is, because BC Sealer is water soluble, I'm going to rinse all that out. So what I'm doing here is I'm just tidying everything up, just finalizing it, making it look pretty. I'm going to just remove a little bit of that gutta percha. If you have difficulty searing, because as I'm watching this, I'm like, wow, that's smooth. But I can tell, but I'm waiting for gutta percha points to come flying out. And I'll be honest, it's taken so much practice. And one of the things you can do is practice on extracted teeth, even just the obturation. It is so helpful just to practice on extracted teeth. Oh my gosh. What I elected to do was just leave. Apparently, I just left the 2 canals joined with gutta percha. It does not matter at all. I used to think it, I didn't used to wonder if it did, but it doesn't make a difference at all. We got everything cleaned out, and then that's it. So thank you so much for joining me. I'm super grateful you're here. We're going to provisionalize this, and then we're going to place a final restoration down the road. Hopefully that was helpful. I'm super grateful for you to be here. If you use Cavit, this is a really great tip. Let me just back up. I know I'm just about on the exit way. If you use Cavit, place your Cavit on a burnisher or any type of instrument like this in a cone. I really appreciate Ruth for teaching me this. And then you just kind of smash it in there and then smudge it around. And it's such an easy technique for doing that. I'm so grateful you're here. Hopefully this was really helpful. I had a great time. Thank you so much for joining me, and we'll talk to you soon. Cheers.
Hey, Ash here, and I wanted to take a second of your time just to introduce our course, Root Canal Like an Endodontist. We've had it for a couple years, and we've had some amazing successes through it. Just confidence building on behalf of our students. And really what happened was, a few years ago, I wanted to create a course to help others, because I know what it's like on your endo journey. A lot of times you don't know what's going on. You don't know if you've ledged it. You don't know what to do if you blocked it. You don't even know if a curved canal, what to do. And what I wanted to do was take all my mistakes and my training from my residency and put it into a affordable online course for everyone around the world to join in. And it's been absolutely amazing. And I wanted to offer to you, check us out at allthingsendo.ca. Once you join the course, you get access into our private Facebook group where all of us answer questions. And I'm telling you, there are questions every day that you might be able to, I'm sure you'll be able to connect with, because sometimes it just takes a little bit of courage to ask a question and then your outcome may be incredible. Anyways, I look forward to seeing you there. allthingsendo.ca. We'll talk to you soon.